Norepinephrine is a neurotransmitter and hormone that mimics the effects of its naturally occurring counterpart in the body. It plays a crucial role in the body's sympathetic nervous system or fight-or-flight response, making it a sympathomimetic. Norepinephrine acts as a mixed alpha-beta agonist, binding to both alpha and beta receptors. However, it has a stronger preference for alpha receptors than beta. To simplify, norepinephrine is mainly an alpha-1 agonist, with mild beta-1 agonist activity, as the activity of the other alpha and beta receptors is less clinically significant. Alpha-1 receptors are mainly found in veins and arteries. When norepinephrine binds to these receptors, it leads to vasoconstriction, which increases systemic vascular resistance. In the veins, this assists with venous return, or blood return to the heart, which increases preload, or ventricular filling, and thus stroke volume and cardiac output. This in turn increases systolic blood pressure. On the other hand, in the arteries, this directly increases diastolic blood pressure. Beta-1 receptors are mainly found in the heart. When norepinephrine binds to these receptors, it leads to a positive inotropic and chronotropic effect, meaning the heart's force of contraction and rate increase. This causes an increase in cardiac output and therefore systolic blood pressure. Even though beta-1 stimulation increases heart rate, a slight decrease may be observed with norepinephrine use. This is due to a reflex bradycardia caused by vasoconstriction, a result of alpha-1 activity, stimulating baroreceptors within the heart. Norepinephrine is also known as levophed, noradrenaline, and norepi. Due to its vasoconstrictive effects, norepinephrine is a potent vasopressor used to treat severe hypotension, such as from shock, especially septic shock. Adverse effects of norepinephrine can include bradycardia, chest pain or discomfort, anxiety, lightheadedness or dizziness, headache, weakness, and phlebitis at the intravenous site, or inflammation of the vein. Norepinephrine should not be used for hypotension without appropriate fluid volume replacement. Norepinephrine is commonly administered as a continuous intravenous infusion in a critical care setting. When norepinephrine is ordered, a range is usually provided, either in micrograms per minute or micrograms per kilogram per minute, based on facility preference. The infusion is then titrated to achieve the target indicated by the MRP. This target is typically a mean arterial pressure or MAP, greater than 60 or 65, but it can also be a specific blood pressure. Exceeding the necessary dose may lead to excessive vasoconstriction, resulting in hypertension, tissue necrosis, and decreased end organ perfusion. A central line is preferred when administering norepinephrine. However, a peripheral IV, preferably into a large vein, can be used for short-term and low doses. It's important, however, to closely monitor the peripheral IV for extravasation or leakage of the medication into surrounding tissue, as it can cause tissue necrosis. If extravasation occurs, immediately notify the MRP and expect an order for phentolamine, which is injected around the site of extravasation. An arterial line is preferred over non-invasive blood pressure for monitoring blood pressure while on a norepinephrine infusion. And when a patient is in acidosis, it causes vasodilation, which decreases the effectiveness of norepinephrine. I hope you found this video useful. If you did, please let me know by giving it a thumbs up, subscribing, and leaving a comment below. Thank you, and bye!